Hi, my name is Andy Liao, and I'm a medical oncologist at the University of Chicago who specializes in neuroendocrine tumors. I want to thank you all for joining us today for our meeting, and thank you to the NETRF for organizing this. So today I'll be talking about an introduction to neuroendocrine tumors. We'll start by talking about what neuroendocrine tumors are, how common neuroendocrine tumors are, what are some of the symptoms of neuroendocrine tumors, how neuroendocrine tumors are diagnosed and staged, and how neuroendocrine tumors are treated. So when we talk about neuroendocrine tumors, or NETs, it's useful to know a little bit about the history of neuroendocrine tumors. Another term that you may have heard people use to describe neuroendocrine tumors is carcinoid tumors. And this was a term coined in 1907 by the German pathologist Siegfried Oberndorfer, who observed a group of slow-growing tumors that are carcinoma-like, meaning cancer-like, but he thought that they were benign cancers, and so he named them carcinoid. We now know that that's not entirely true, and that in fact most neuroendocrine tumors are cancers that can grow and spread to other organs. Neuroendocrine tumors are tumors that can arise from neuroendocrine cells. So these are cells that are found all over the body, and the name neuroendocrine refers to the fact, so for neuro, it means that these cells can receive neuronal or nerve input, and endocrine means that these cells can secrete hormones. And so here on the right-hand side of the slide, you can see a close-up picture of the lining of your small intestine. And scattered about the cells that line the small intestine are these neuroendocrine cells as shown in green. And so as you can see, these neuroendocrine cells, they receive input from nerves, and they can secrete hormones like serotonin, histamine, insulin, gastrin, glucagon, somatostatin, and VIP. Neuroendocrine tumors can originate from any side of the body, and traditionally we classify them based on their origin from embryological development. So we have the foregut neuroendocrine tumors, which include neuroendocrine tumors arising from the thymus, esophagus, lung, stomach, duodenum, and pancreas. We have the midgut neuroendocrine tumors, which include tumors arising from the appendix, ileum, cecum, and the ascending colon. And then we have the hindgut neuroendocrine tumors, which arise from the distal bowel or the rectum. Within the group of pancreatic neuroendocrine tumors, we have gastrinomas, insulinomas, glucagonomas, VIPomas, and somatostatinomas. And finally, it's important to note that for many of our patients, we never find the primary site of the tumor, and those are called neuroendocrine tumors of unknown primary. One way we can classify neuroendocrine tumors is by whether or not they cause symptoms of hormone overproduction. So we call them functional neuroendocrine tumors if they cause symptoms of hormone overproduction. And some examples are insulinomas, gastrinomas, glucagonomas, VIPomas, and somatostatinomas. We call them non-functional neuroendocrine tumors if they do not cause symptoms of hormone overproduction. And so one example is poorly differentiated neuroendocrine carcinoma, which generally does not cause symptoms of hormonal overproduction. Another key feature that I want to point out about neuroendocrine tumors is that many of them may express something called somatostatin receptors on the surface of the cells. So if you can see on the left-hand side, there is a cartoon of a neuroendocrine tumor cell, and on the surface of the cells, there are these receptors shown in gray that are the somatostatin receptors. And these are where the somatostatin hormones, but also some of our drugs can bind to, as we'll talk about later in the treatment section. And the other thing to note is that we can determine whether the tumors express somatostatin receptor with our imaging, with gallium DOTATATE PET scan, for instance, as shown in the right. And this may have important treatment implications, as we'll get to later. So I'm sorry for the very, very confusing terminology that we use to describe neuroendocrine tumors. You may have heard us talk about them as neuroendocrine neoplasms, neuroendocrine tumors, and neuroendocrine carcinomas. So what's the difference between these three terms? So in the context of neuroendocrine tumors, we use the term neuroendocrine neoplasms, or NENS, as a broad umbrella term that includes both neuroendocrine tumors and neuroendocrine carcinomas. And to further expand on the distinction between these three entities, so this is the 2019 World Health Organization classification of neuroendocrine neoplasms. So in this classification, neuroendocrine neoplasms are classified according to their grade, to their differentiation, by things like the Ki-67 and mitotic index. And so we'll go over in the next few slides what each of these terms mean. But as you can see on the left-hand column, there are the grade 1, grade 2, and grade 3 neuroendocrine tumors. There are the grade 3 neuroendocrine carcinomas, which include small cell type and large cell type. And finally, there's an entity called mixed neuroendocrine and non-neuroendocrine neoplasm. And in general, as you can see, the tumors that are well differentiated are termed neuroendocrine tumors. On the other hand, the tumors that are poorly differentiated are termed neuroendocrine carcinomas. So what is tumor differentiation? So differentiation refers to how similar the tumor appears compared to the normal neuroendocrine cells that the tumors originated from. So in other words, it's basically how the tumors look under the microscope morphologically. So here in the example, you can see on the left-hand side, this is a microscopic view of a well-differentiated neuroendocrine tumors where the cells don't look as aggressive. On the right-hand side, this is a microscopic view of a poorly differentiated neuroendocrine carcinoma, and morphologically, the cells look very aggressive. Another way we classify neuroendocrine tumors is based on tumor grade. And what grade means is how proliferative the cells are. In other words, how many cells are actively dividing and growing at a given time. So one of the ways to determine grade is something called the mitotic index. So you all remember from high school biology that mitosis is the process that the cells use to divide and grow and make copies of themselves. So in the left is a cartoon of what mitosis looks like. It turns out that we can actually see cells undergoing mitoses under the microscope. So in the right-hand side of the slide, you see a picture of a neuroendocrine tumor, and I've circled 3 of the cells that are undergoing mitosis. So this is how the pathologist can determine the mitotic index to see how proliferative the tumors are. Another way to assess tumor grade is something called the Ki-67 index. So this is a stain that the pathologist can use to highlight the cells that are proliferating. So on the top left-hand side of the pictures, you can see a microscope picture of a grade 1 neuroendocrine tumor. And you see that only a few of the cells are highlighted in brown, and these are the cells that stain positive for Ki-67. So this makes it a low-grade tumor because only those few cells are proliferating. On the top right-hand side, you see that for a grade 2 neuroendocrine tumor, there are more cells that are proliferating. And on the lower on the bottom left hand side of the picture, you see a grade 3 neuroendocrine tumor where even more cells are proliferating. And on the bottom right, you see a grade 3 neuroendocrine carcinoma where almost all of the cells are proliferating. And just a note about poorly differentiated neuroendocrine carcinoma. As you recall, in the classification system, we talk about large cell type versus small cell types. And that really refers to how the cells look under the microscope. So on the left-hand side, you see an example of a large cell neuroendocrine carcinoma where the cells look large. On the right-hand side, you see a picture of a small cell neuroendocrine carcinoma, which is comprised of these small cells. And not only are they morphologically different, but they also have different genomic characteristics and also different biology. So now that we know a little bit about what these different terms mean, we can go ahead and take another look at this WHO classification of neuroendocrine neoplasms. So as you can see, tumor grade and tumor differentiation are generally concordant, but there's an exception. So you can see in the middle, there is an entity called grade 3 well-differentiated neuroendocrine tumors, which means that the cells morphologically don't look aggressive, however, they are proliferative. On the other hand, all poorly differentiated neuroendocrine tumors are high grade or grade 3. And so because you see that there's such a complicated classification system and there's so many different nuances and there's some degree of subjectivity to classifying neuroendocrine tumors depending on how the cells look under a microscope, every patient with a neuroendocrine tumor needs to have their pathology reviewed by an experienced pathologist to make sure that they have the right diagnosis, because this can have very important treatment implications. So how common are neuroendocrine tumors? So in the US, the incidence of neuroendocrine tumors is rising. So when we talk about incidence, what we mean is the number of new cases over a given period of time. So the incidence of neuroendocrine tumors in the US is currently about 7 per 100,000 persons. And this is a graph from the SEER database, and you can see in the yellow line that over the past 3 decades, the incidence of neuroendocrine tumors has steadily increased. In the gray line, you see the incidence of all cancers, and you can see there was a slight increase in the 80s and 90s, but then the incidence of all cancers has leveled off recently. If you look at the incidence of neuroendocrine tumors by subtype, you see that the incidence of almost all subtypes of neuroendocrine tumors are increasing. The one with the highest incidence is lung neuroendocrine tumors, followed by small intestine neuroendocrine tumors, rectal neuroendocrine tumors, and pancreas neuroendocrine tumors. And so the increase in incidence in neuroendocrine tumors may be in part due to our increased awareness and better classification and better diagnosis systems. Another way we can use to describe how common neuroendocrine tumors are is something called prevalence, which is in a given time, what percent of the population has a neuroendocrine tumor. So as you can see on this graph, the prevalence of neuroendocrine tumor has also steadily increased over the past few decades. And that reflects the indolent nature of neuroendocrine tumors in general, but also the fact that neuroendocrine tumors are generally living longer nowadays. So moving on to talk about what are some of the symptoms of neuroendocrine tumors. So when we think about symptoms, we can think about symptoms related to the tumors themselves. So this may include pain. So for example, abdominal pain from a tumor in the small intestine, or pain from tumors that are spread to other sites, such as bone metastases can cause can cause lots of pain. The tumor can cause obstruction, so this can include examples like bowel obstruction from a small intestine neuroendocrine tumor, or the liver metastases can cause bile duct obstruction leading to jaundice. The tumor may cause bleeding, and the tumor may cause patients to have an overall sense of just feeling unwell, which includes symptoms like fatigue and weight loss and loss of appetite. Neuroendocrine tumors also cause symptoms by the hormones that they secrete. So here are some examples. So for patients with insulinomas, they can have symptoms of low blood sugar such as weakness, sweating, tremors, palpitations, and etc. Patients with gastrinomas can have abdominal pain, can have refractory stomach ulcers, and a secretory diarrhea. Patients who have glucagonomas can have a special type of rash, a dermatitis, called migratory necrolytic erythema. They can have diabetes, they can have diarrhea, and they can get blood clots. Patients who have VIPomas, they get profuse watery diarrhea, and as a consequence can get dehydration and severe electrolyte abnormalities. And finally, patients who have somatostatinomas can get diabetes, they can get gallstones, fatty stools, and weight loss. We also think about something called Carcinoid Syndrome when we think about how neuroendocrine tumors can present. And Carcinoid Syndrome happens because many of these neuroendocrine tumors can secrete serotonin, or 5-HT, as well as many other bioactive substances. And the consequence of having too much serotonin or other biosubstances on board is that can lead to symptoms like flushing, diarrhea, shortness of breath, wheezing, and heart palpitations. And long-term consequences can include changes to the heart valves, so carcinoid heart. It can cause something called mesenteric fibrosis, so scarring within your abdomen. It can cause pellagra, and it can have neuropsychological consequences. So moving on to talk about how neuroendocrine tumors are diagnosed and staged. So as I just told you, these neuroendocrine tumor cells may make hormones and other substances that are released to the bloodstream that we could measure. So some examples are chromogranin A, pancreatic polypeptide, and something called neurospecific anolase, in addition to serotonin and 5-HIAA. The problem is none of these markers are perfect, and in fact, many of these markers, such as chromogranin A, can be falsely elevated by other medical conditions or medications. And so in general, we should not be using the markers alone as a means of diagnosis. Sometimes they can tell us prognostic information, such as the 5-HIAA, and sometimes significant trends and changes in the markers can give us a sense of how the patient is responding to treatment. However, in general, we shouldn't be relying solely on the markers to make our treatment decisions. So in other words, we should treat the patient and not the number. One of the most important things in diagnosis and staging is getting a high-resolution imaging to determine the extent of the cancer. And so some of the ways we can accomplish this is by doing CT scans and MRIs. So here are the CT and MRIs from one of my patients. You can see on the left-hand side of the picture is an example of a CT scan. And this is a cross-section showing a cross-section of the patient's liver. And you can see that there are areas that appear lighter than the background. Those are the liver tumors. On the right-hand side, you can see what these tumors look like under the MRI. And as you can see, in this particular instance, the MRI really gives a much clearer picture of the liver tumors. And in fact, you see many, many small liver tumors that are more visible on this MRI. Another type of imaging we can use for diagnosis and staging is functional imaging done by nuclear medicine. And so these are called PET scans. And so here is a type of PET scan called gallium-68 DOTATATE PET scan, which we use commonly for neuroendocrine tumor patients. So this is a type of PET scan that takes advantage of the fact that the neuroendocrine tumor cells express the somatostatin receptor. And the tracer that these patients get for the PET scan actually binds to these somatostatin receptors to make the tumors light up. So you can see this is the same patient. This is what their gallium DOTATATE PET scan looks like, and you can see how the liver tumors light up intensely with the gallium DOTATATE PET scan. Another type of PET scan that we use in cancer diagnosis and staging is called FDG PET scans. So when you talk about a conventional PET scan, this is what people refer to. This is the regular type of PET scans. And the way that these PET scans work is that the tracer of the PET scan is essentially radioactive sugar. And so the tracer will go after cells that are metabolizing, meaning actively proliferating. And as I just told you before, not all neuroendocrine tumors are rapidly proliferating. So for example, the low-grade neuroendocrine tumors, they really don't proliferate that much, and therefore they may not light up that much on an FDG PET scan, as is in my patient's case, as you can see here. Here on her FDG PET scan, none of her liver tumors actually lit up, even though they're there, but because they're not proliferating and using sugar, they don't light up as well on this type of PET scan. So it's very important to know when to use what type of PET scan. And so, when do we use gallium DOTATATE PET scans and when do we use FDG PET scans? So there is a spectrum and a continuum, as you can see here, moving from grade 1 neuroendocrine tumors to grade 2 to grade 3 neuroendocrine carcinomas. In general, the grade 1 neuroendocrine tumors tend to express somatostatin receptors, and they tend not to be very hypermetabolic. As you move towards the right of the spectrum, towards the grade 3 neuroendocrine carcinomas, these tumors tend to be very hypermetabolic, but they tend not to express somatostatin receptors. And so therefore, tumors that are grade 1 tend to light up better on gallium DOTATATE PET scans, whereas tumors that are grade 3, especially the neuroendocrine carcinomas, tend to light up better on the FDG PET scans. And of course, in the middle category, there is a group of neuroendocrine tumor patients whose tumor will light up on both FDG and gallium PET scans. And finally, talking a little bit about staging of neuroendocrine tumors. So we can describe neuroendocrine tumors based on their anatomic stage, but also based on their clinical stage. So anatomic staging is fairly complicated. You might have heard of something called TNM staging or AJCC staging. And so the specific criteria vary depending on the origin of the tumor, but the general takeaway is that stage 1 neuroendocrine tumors are those that are localized. Stage 2 neuroendocrine tumors are localized but more advanced. Stage 3 neuroendocrine tumors are those that have spread to the lymph nodes. Stage 4 neuroendocrine tumors are those that have spread to distant sites, such as the liver and the bone. But anatomic stage sometimes is not very helpful in terms of informing us the treatment considerations. And so sometimes we use clinical staging, which gives us a better sense of how we would approach that specific patient. So patients with localized clinical stage are patients whose tumors are confined to the primary tumor and to the regional lymph nodes. Patients who have liver-limited metastases are patients whose tumors have only spread to the liver, which could potentially make them a candidate for treatments that are directed towards the liver. And then we have patients who have widely metastatic disease. In other words, their cancer is spread to multiple distant sites across the body. And finally, I wanted to talk a little bit about the treatment landscape of neuroendocrine tumors, and this will be further expanded on by other speakers in today's symposium. And before we talk about treatment, I want to highlight that observation or active surveillance can be very appropriate in a select patient population. So these are generally patients who do not have symptoms, or they have a low tumor burden, and they have very slow growing tumors. So one example is this patient over here that just has a very tiny liver tumor. So this patient can be safely observed. When we think about treatment, surgery is one of the treatment modalities we use in neuroendocrine tumors, and that involves both resecting the primary tumor but also debulking liver metastases. There is also something called liver-directed therapy, which are treatments we do directly to liver tumors. And this includes ablation, so these are percutaneous techniques that can involve things like radiofrequency ablation or microwave ablation for small liver tumors, or it can involve something called embolization, which is a technology that takes advantage of the fact that the liver has two different blood supply systems. So the healthy liver tissue generally is supplied by the portal vein system, whereas the liver tumors in general are supplied by the hepatic artery system. And because of that, you can selectively go in through the hepatic artery system to burn off the blood supply of the liver tumors or to deposit radiation beads or chemo beads within the liver. And we have systemic therapies, which are treatments that treat the entire body. And so this may include somatostatin analogs, so medical treatments that bind to the somatostatin receptors. This may include targeted therapies that target different pathways that the tumor cells use to grow and spread. And then this may include cytotoxic chemotherapy, which is chemotherapy in the conventional sense and goes after rapidly dividing cells. And we have a treatment modality called peptide receptor radionuclide therapy, or PRRT, which is a systemically delivered radioactive drug. And it takes advantage of the fact that most of these neuroendocrine tumor cells express the somatostatin receptor. So the drug binds to the somatostatin receptor and delivers a radioactive compound with it. So one example is lutetium DOTATATE or Lutathera, which is the PRRT drug that is currently FDA approved in the US right now. So I hope you've gotten a sense that neuroendocrine tumors are a very diverse group of tumors, and there are many different treatment options on the table. And our goal is to use the right treatment at the right time so that we can keep our patients healthy for as long as we can. And this really involves collaboration between all of the different specialists that take part of treating patients with neuroendocrine tumors. For the rest of today's symposium, you'll hear talks from many different specialists about their perspectives about what they do in treating neuroendocrine tumor patients. So that concludes our talk. I want to thank all of our patients and family. I want to thank the NETRF for putting together this conference and our whole University of Chicago team. And thank you again for joining us.